Healthcare associated infections. There are four major healthcare associated infections: CAUTI, the full form is catheter associated urinary tract infection; CLABSI, central line associated bloodstream infection; VAP, ventilator associated pneumonia; SSI, surgical site infection. Okay, so the full form should be known for examination purpose. CAUTI, catheter associated urinary tract infection. When a urinary catheter is not put correctly, not kept clean, or left in the patient for too long. Okay, these are the reasons where the germs can travel through the catheter, infect the bladder and the kidneys, thus putting the patient into the CAUTI criteria. Okay, catheter-associated urinary tract infection account for approximately 40% of all the hospital-acquired infection annually, with full 80% of these are hospital-acquired urinary tract infection, which is attributable to indwelling urethral catheters. So if there are 100 cases of hospital-acquired infection, 40% of them, 40 cases most probably will be CAUTI. And even among CAUTI, 80% of CAUTI was due to indwelling urethral catheters. The remaining 20% is due to quantum catheters or other modes of catheterization, intermediate catheterization, etc. Next, indications for catheterization. Indwelling catheter should be placed only when indicated, and it should be removed as soon as possible. When it is no longer in use, when it is not recommended, it should be removed. Only in few indications, only in that case, indwelling catheter should be placed. So these are few examples: prolonged immobilization. For example, there was a multi-organ trauma, okay, pelvic fracture, patients who are suffering from hemiparalysis or paralysis, okay, the patient who are having are on short-term management for urinary incontinence. These are the examples. And to measure urinary output, for example, in kidney transplant cases, or patients generally suffering from some kidney failure or kidney related diseases. Okay, so urinary output should be measured to the milliliters. So in that case, indwelling catheter is used. Treatment for bladder outlet obstruction, okay, and in post-operative management also indwelling catheter is used. These were the indications and recommendations to prevent CAUTI. Okay, first thing, personal. The person who is putting the CAUTI, they should follow all the aseptic technique. Correct placement procedure should be followed. Catheter use, the catheter should be used only when it is required, and when it is not required, it should be removed. So that is another example of preventing UTI. And as long as it is required, only that time it should be used. After that, it should be removed. Hand hygiene should be followed before and after the procedure. Catheter insertion, during that it should be inserted using the aseptic technique, sterile equipment, gloves, drapes, sponges, appropriate aseptic solution for periurethral cleaning the genital area, etc. should be done before catheter insertion. And after catheter insertion also, proper catheter care should be given. So these are the recommendations to prevent CAUTI. Closed sterile drainage. Catheter collection system should remain closed and not open unless absolutely necessary to check to give the urine samples for urine analysis and everything. If the patient is on catheter, the catheter collection system should be remain closed, and it should be on the distal end. Should not be near the perineal region. Replace the catheter and collecting system if there is any break in the aseptic technique or leakage. If you found that while during catheter care you were not you were not following the correct procedures, or you saw some break in the aseptic technique, you should report it, and then immediately the catheter should be replaced. Continuous irrigation of bladder with antimicrobials should be avoided, because there is a normal flora which is there in the perineal area that should not be killed. Otherwise, it will again imbalance the pH of the perineal area, and it will lead to further UTIs. Use distal end of the catheter for sampling pot or for collecting the urine for urine analysis. Unobstructed urinary flow should be maintained, because if there is any obstruction, means urine will be collected there for a long period of time, and a urine which is stagnant will lead to more microbial growth, and thus putting patient at the risk of getting CAUTI. Meatal care. Meatal area is the area where the catheter enters the urethra. So meatal care should be used with proper aseptic solutions. Surgical site infection. So surgical site infection is an infection that occurs after the surgery in the part of the body where the surgery was performed. Okay, it's not like you have done an abdominal surgery and you've got an infection somewhere in your extremities. That will not be not a surgical site infection. Where the surgery was done, where the incision was made, there after surgery infection happened. Okay, so that is surgical site infection. So CDC describes 3 types of SSI: superficial incisional SSI, deep incisional, and organ or space. Okay, in superficial, with the name itself, we can understand the epidermis and the dermal layers of the skin will be involved. In deep incision, the muscle may be involved, and in organ or space, the organ where the surgery was performed, that will also be involved. Okay. Source of pathogens: endogenous flora of the patient's skin, mucous membrane, or hollow viscera. The flora which is already present within the body, that can become a source of pathogen. Staphylococcus aureus from exogenous environment, maybe from the hand, or it is been transmitted from the healthcare professionals who were the part of the surgical procedure. Okay, so that can be a source of Staphylococcus aureus infection. Processes or implant placed during the surgery, personal, operating room, tools or instrument, etc. For example, if you're not following an aseptic technique, or proper sterilization and disinfection was not done for the instruments which has been used, or the personals didn't follow proper hand hygiene, or didn't follow proper PPE technique, etc. And operating room itself was contaminated. Tools used and instruments used were contaminated. So these may be the reasons why this may be the reasons which may lead to pathogenic infection in the surgical site. So this is the classification of surgical wounds. It is given in page number 66. Okay, you can classify the surgical wounds into clean, contaminated, and dirty. In clean, there is no infection, there is no inflammation, it is closed, it is a very straight line, and it is like usually when you do laparoscopy, mastectomy. Okay, these are the examples where the clean wounds you can see. Clean. Contaminated means little bit inflammation will be there. Okay, that is clean. Contaminated, it is predominantly clean, but there are some contamination which has led to inflammation, etc. In contaminated, it is pathogens have entered the surgical site, open, fresh, accidental wounds, or which when you suffer a major trauma outside, okay, that may lead to contaminated wounds. Spillage from the GI tract into the surgical area, that may lead to contaminated wound. Contaminated wound means pathogens are present. Dirty wounds mean old traumatic wounds. The wound was much old, but because of the presence of a variety of pathogens in that wound, it is now become old, purulent. Okay, perforation, there is a perforation, and organisms were present even before the surgery was done. Okay, so that's an example of dirty wound. So wound infection. An infected wound is a wound that bacteria or other microorganisms have colonized, causing either delay in the healing of the wound or deterioration of the wound. Okay, wound infection can also occur when the body's natural immune defenses are overwhelmed and it cannot cope up with the normal bacterial growth. So this is the meaning of wound infection. Okay, contamination, it is the presence of pathogens on the surface of the skin or wound. Pathogens, if there is a presence of pathogen, means there is contamination. Colonization occurs when contaminants multiply significantly and the body's immune system is overwhelmed. In contamination, where pathogens were present, but in the stage of colonization, these pathogens have begun to multiply. Bioburden. Bioburden is the number of contaminating microbes on the surface of the wound. Biofilm, it is the extracellular matrix structure that attaches itself to the wound surface tissue and protects the microbes from the host defenses. It must be scrubbed off the wound. You can see the example here of biofilm forming here. Okay, these are the microcolony formation, and here they have multiplied, and this white layer which you can see, which is covering this, which is protecting this flora, this contaminating pathogens, it is protecting this white film. Okay, that is called the biofilm. Okay, that's the matrix which will protect the pathogens. So that has to be scrubbed off the wound. Local indicators of wound infection. There will be redness where the wound is. It is not, if it is not healing properly, there will be redness. There will be increased exudate or pus formation. Changes in the exudate color. The pus changes from white color to yellowish green. Okay. Malodor, that is smell, bad odor coming out from the wound. Localized pain near the incision. Localized heat along with redness. It will be little warm to touch. Delayed healing, it is not healing properly. Pruned wound breakdown. Okay, it is when it is not healing properly, it spreads. So that are the local indicators. When you look at the wound, the area where the incision was done, what all symptoms and signs you can see. Okay, this is now we are seeing systemic indicators. So increased systemic temperature, overall the body temperature will rise. General malaise, the patient will generally feel very tired and fatigued. Increased leukocyte count, when is sent for the blood for examination, the WBC count will be high. Lymphangitis, the lymph nodes near the surgical wound or even away from the surgical wound will be inflamed. Any of these above clinical indicators are present, microscopy and culture wound swab should be considered. Surgical site infection prevention. Preparation of the patient. When you are preparing the patient, you have to identify and treat all the infections removed to the surgical site before the elective operation. For example, if the patient is suffering from tuberculosis, okay, the tuberculosis has to be treated. The patient should be smear negative, then go for elective surgery. Okay, next example is like for the hospital stay, you have to make sure hospital stay is as short as possible. And when removing the hair pre-operatively, in that you have to check that before the surgery, around the incision area, the hair has to be removed so that it will not interfere with the procedure. Okay, then control the blood glucose level. Okay, that comes as the preparation of patient. Encourage smokers and everyone to reduce the use of a cigarette or stop smoking before the surgery. And you have to withhold any blood products provided to the patient before surgery. Okay, if any blood products are being used by the patients before surgery, that has to be withheld. And patients encourage that patient should shower or bath at least the night before the surgery, and aseptic agent should be used for preparing the site. So these are the few guidelines which is given in page number 66, which you can read through, which comes under the preparation of the patient. Antimicrobial prophylaxis, you have to administer prophylactic antibiotics, especially targeting the pathogens that may cause surgical site infection. Okay, and it has to be administered via the IV route, and according to the bactericidal concentration, it should be timed. And maintain the therapeutic levels agent in the serum tissues throughout the operation until at the most few hours after the incision is closed in the operating room. Okay, so you have to make sure that when you're providing antibiotics during the surgery, it has to work till the end of the surgery, so that in between you are not increasing the dose of the antibiotics and causing any resistance or putting the patient at the risk of antibiotic resistance. So make sure whatever antibiotics you are providing, It should last, its therapeutic value effect should last throughout the surgery. Microbiological sampling, okay, routine environmental sampling, perform microbiological sampling of the environment, surfaces, air, etc. Okay, it has to be done on regular basis. Cleaning and disinfection should be done. All the visible or soiled contamination of the blood and other body fluid surfaces should be removed using the spillage control protocols. Surgical equipments and everything should be sterilized properly. Instruments used in surgery, okay, all the disinfection policy should be maintained here. Aseptics and surgical technique adhere to the principles of aseptics and intravascular devices, epidural anesthesia catheters when dispensing and administering intravenous drugs, and assemble all the sterile equipment and solutions immediately prior to the use. You don't have to run for an instrument in between the operation. Okay, so if you know what all instruments are required for a particular surgery, everything should be assembled and then proceed for the surgery before the surgery. Sterilization of the surgical instruments, make sure it is properly sterilized. Surgical attire and drapes should be sterilized. Post-operative incision care is done in the post-operative room, and sterile dressing should be done for which it should be kept for 24 to 48 hours post-operatively after the incision has been closed. Wash hands before and after dressing changes or any contact with the surgical site, and use sterile technique to change the incision, dressing, etc. This is the post-operative incision care. And surveillance system should be there. There should be a record particularly for SSI, in which if at all any SSI cases come across, the nurses or the infection control nurse should note down the time, the date of surgery, where the surgical site infection has took place, what are the reasons which led to the SSI, and corrective action should be taken. Ventilator-associated pneumonia. So ventilator-associated pneumonia is a complication of mechanical ventilation and is defined as the occurrence of pneumonia in the patient undergoing mechanical ventilation for at least 48 hours. So once a patient is been put on ventilator, after 48 hours, the patient has started pneumonia, showing the symptoms of pneumonia, which means that the patient has now contracted ventilator-associated pneumonia, which is a healthcare-associated infection. Occurs by aspiration of bacteria colonizing the oropharynx or upper GI tract of the patients. So either from the oropharynx or from the GI tract, the bacteria can be aspirated into the trachea. Okay, and through where this bacteria will start colonizing and further infection will spread. That is the mechanism. So prevention of VAP. Hand hygiene has to be followed. Guidelines and 5 movements of hand hygiene should be followed. Healthcare workers should wear mask, gown when you know that respiratory secretion, you're anticipating respiratory secretion for the procedure. Elevate the head end of the bed to 30 to 40 degrees to prevent aspiration. And remove the devices as soon as indicated. Do not keep the patient for a very long time on the ventilators. As soon as it is advised to remove the patient from ventilator, it should be done. Perform orotracheal rather than nasotracheal unless contraindicated. Use non-invasive ventilation wherever possible. Only when it is required, it is the last resort, then only ventilation has to be done. Then only the patient has to be put onto ventilator. Avoid histamine receptor blocking agents or proton pump inhibitors for who are not at risk of developing stress in ulcers. So unnecessarily do not give these medications. Regular oral care with antiseptic solution should be done. Avoid gastric overdistillation. If there is overdistillation in the gastric area, there will be aspiration or regurgitation, which may lead to aspiration of the gastric fluid into the trachea. Again, it will lead to VAP. Remove condensate from the ventilatory circuits. Change them only when they are visibly soiled or malfunctioning. So when during the ventilation process, when the condensate will form into the pipes of the ventilators, it should be changed only when you can visibly see it is soiled or when the ventilator is not functioning properly. Okay, only then the condensate should be removed. Store and disinfect the respiratory therapy equipment properly. After every use, disinfect the and sterilize the ventilatory pipes, laryngoscopy, device and everything, and store it properly. Educate the healthcare worker and develop a surveillance system for VAP. Central line associated bloodstream infection. It's a primary laboratory confirmed bloodstream infection in a patient with a central line at the time of within 48 hours prior to the onset of symptoms. The infection is not related to an infection from another site. So after placing the central line, after 48 hours, the laboratory has confirmed a bloodstream infection. So that is CLABSI. You have to follow again hand hygiene, aseptic technique while placing the catheter, and proper care of the central line catheter area should be done with aseptic solutions. Maximal sterile burial precautions during catheter insertion while we are on the procedure, while the patient, doctors or the nurses who are providing the central line procedure, ensure that maximum sterile burial precautions are done. You are not making the sterile equipments used in the central line insertion procedure, you're not making them unsterile. Strictly follow the catheter site pressing regimens. Select the catheter insertion technique and insertion site with the lowest risk of complication. For example, the central line used in femoral area is at much risk of getting complication than the clavicular central line, etc. Avoid femoral vein for adult patients. Use subclavicle vein in adult patients. Promptly remove the central line when no longer essential. Do not routinely replace the central line just for the purpose of reducing infection. Okay, because you don't have to regularly replacing and again putting back can also lead to the risk of infection. No need to replace the peripheral venous catheters more frequently than 72 to 96 hours. That is the IV line, IV catheters which you apply. Leave the peripheral venous catheter in place in children until IV therapy is complete unless complications occur. So again, removing and replacing the PVC often in children is not recommended. Develops again, surveillance system should be there for CLABSI. Thank you.